to do was to build it with genomics. And then it was a radical idea. Remember, this was just before the pandemic, when everybody then learned that genomics was a very versatile mechanism. So what we did at NCDC, National Center for Disease Control, is our coordinating center. Our national reference lab is at the University College Hospital, Uganda. We twinned them with my lab, which had genomic capacity to perform many of these quality functions using genomics. I'm not going to talk about the operational challenges we had to do this, even though this is important. I'm just going to say that we have already published this in Clinical Infectious Diseases. It's open access. If you're interested, you can go take a look. Instead, what I'm going to talk about is what we gained in addition to the reference lab function by using genomics for this purpose. And the first thing I'd like to talk about is what we have understood even more than the Sentinel study by using genomics in the surveillance system in Salmonella. And then the second, I'll just close when I talk about Klebsiella. So because the surveillance system requires all sentinels to send in their blood isolates to the National Reference Lab for verification, and we do the verification by sequencing, we had an almost automatic way to see whether what the sentinel that was figuring out burden was actually more representative. And what we found was that indeed, here in orange, most of what we find in Nigeria is actually typhoid. So we know that the vaccine will have that impact, not just in Ibadan, but more broadly. We even found that the next order is going to be on Klebsiella. Klebsiella is actually because it's largely a commensal, lives in our guts, it lives in the guts of animals, it lives in the environment, it does very well in multiple environments. And this allows it to pick up resistant genes very, very easily and transmit them into hospitals. Klebsiella, its natural biology allows it to hold plasmids, mobile genes, more commonly than other organisms like Salmonella. And if you've read the Graham report about the global antimicrobial resistance, you'll know that Klebsiella is the sort of the third most common organism that we're worried about worldwide. So one of the problems with hospitals are lovely, but what that means then is that people who are seeking care in hospitals can sometimes acquire an illness because they sought care. And these healthcare-associated infections are really the dark side of antimicrobial resistance. And they're more common in African settings because we have challenges implementing infection prevention and control interventions. So what we often do in African countries is to use antibiotics as a protection against bacteria. And this is actually creates a ratchet effect where we have a greater problem with resistant healthcare-acquired infections. So because we sequence the isolates that come from our sentinel sites in the antimicrobial resistance surveillance system, we can see outbreaks that the local sites have missed retrospectively. And the retrospectively there is the unfortunate word, because it would be ideal for us to be able to see these outbreaks when they're in play and be able to do something about them. As you can see on the figure, if you want to read trees, but if you're not, just read the tables. Some of these outbreaks are caused by resistant Klebsiella, and some are even caused by sensitive Klebsiella. They could be eliminated even using antibiotics if we identify them at the point where they're happening. And so this is why we need to think about increasing turnaround times for support genomics in order to be able to identify outbreaks as they happen and provide feedback that could support infection prevention and control. Neonatal sepsis is a huge problem in our hospitals. Most neonatal sepsis incidents are actually healthcare-acquired infections. And they are a major reason why, although death in is falling, deaths in neonates are falling much slower. So we have to really focus on how to deal with neonatal sepsis. And one of the most common causes of neonatal sepsis, particularly in African settings, is Klebsiella. The good news is that there's a move to develop vaccines against Klebsiella that will be administered maternally, so that children born of mothers will be less likely to acquire a Klebsiella infection in a healthcare situation. This is not the only solution, but it's certainly something that would help. Unfortunately, there are thousands of different cell bars of Klebsiella, and so the question becomes, which ones do you put in the vaccine? And there have been early studies to sort of look at which variants are circulating, and what you can see from this map, as with many maps, is that there are fewer such studies on the African continent. And if you look closely, you see that with the exception of O1, which is common worldwide, there's not a variation within the African continent. So we need to be able to understand what is circulating and how. So for us, now that we have genomic data that we're using for surveillance, it's very easy to just interrogate those genomes without any more cost and ask, well, which cerebrals are there? And then we can find that, yes, O1 is the most common as it is elsewhere, but why? We have a lot of O5, and nobody knew this before we started sequencing the genomes. And we can feed these data into data that people who are developing the vaccines can use. Okay, so essentially, you know, we had often said, we being someone like me who does science studies research and is annoyed by the fact that biomedicine is not contributing enough to healthcare. I think genomics is an exception. I think it's actually helping us, particularly in the area of bacterial infectious diseases. And I hope I've been able to show you the value of blood culture-based surveillance for antimicrobial resistance, genomic surveillance, and owning this genomic surveillance nationally, and not just using it in research initiatives. How important all of this is. We are actually working with Africa CDC on a forthcoming roadmap for the best use cases for genomic surveillance of antimicrobial resistance, and I wanted to point out that neonatal sepsis and invasive salmonellosis have come up as two of those use cases. So please look out for that report, which we hope should be out sometime early in 2024. Before I end, my time is actually up, I want to just very briefly go over ways forward. First of all, bacterial bloodstream infections are neglected, and they continue to be neglected. Many medical lab scientists come into our labs without ever having done or been taught to do blood culture. I think this has to change. We also have to think about how to mainstream genomics, genomic science so that it can leverage the data that they're able to generate. We need to deal with supply chains. When we talk about supply chains in the genomic arena, we're often talking of library prep kits and sequencing kits and so on. But this goes down to blood culture bottles and materials that are needed for bacteriology. And then we need to think about ways to leapfrog blood culture, because even if we do everything I said, it still won't be accessible to most people on the African continent. So there's work going on now thinking about other ways to diagnose diseases like typhoid, and I think it needs to be wrapped up. So I'll just end by thanking our funders, thanking especially the National Center for Disease Control in Nigeria, who work closely with this, and other collaborators. Thank the Severe Typhoid in Africa program, which did the burden studies in Ibadan, as well as the members of my group who are involved in supporting genomic surveillance for NCDC. I want to thank you for your attention, and I'll be happy to take questions during the Q&A. Thank you.
Thank you so much. I'd like to invite Dr. Kibedi to the stage.
Good morning. Yeah, I'll be talking on the importance of lab governance, which actually was mentioned a couple of times, and also the importance of coordinated lab systems for our surveillance and healthcare services. So you agree with me that there has been significant investment in the lab system in the last 20 years. We had the opportunity to have advancing diagnostic technology, having multiplex testing, point of care, self-testing. Those were not really something that we did before. And we have seen today that quality is a common language in laboratory programs. And we have a number of laboratories accredited. This was captured in Ambassador John Kengason's presentation. So exponential increase in terms of accreditation of labs. A couple of years ago, the role of laboratory manager means getting the test done but today we understand that the role of lab management is much more than that. It's really addressing quality. It is strategic planning. It is everything. So it is really an important change. So, however, even if there has been an advance in laboratory science, still we have a lot of challenges on lab governance. That's where I wanted to emphasize. Many countries don't have lab directorates. Some have, but they don't have the authority. In some countries, the lab directorates are led by non-laboratory professionals. That can happen. And then, in most cases, the lab directors are there, but they don't have, budget line, the authority, the decision power on resources. And then laboratory systems continue less resources. And in many global and continental negotiation tables on resource allocation, you don't find usual lab people. I doubt, if lab has been well represented in today's pandemic treaty and all those discussions happening at a global level. So one of the most important functions of laboratory leaders is establishing lab strategic plan. We did the assessment in few countries in terms of the implementation status of lab strategic plan, and based on our assessment, around 67.7% of countries do have a lab strategic plan. Around 16%, they are in draft stage, has not been approved, and some 16% they don't have the plan at all. This one looks good. Two-thirds of countries having a lab strategic plan. However, if you see the content, the lab strategic plan tends to address usually vertical disease programs, more focused on HIV, TB, malaria, and it usually doesn't address emerging and re-emerging infectious diseases, outbreaks, surveillance. And in the next slide, we looked a deep dive into those countries which say they have strategic plans. So the gap is, out of those countries that have reported they have strategic plan, only 3 countries have implemented, and they have done midterm review or interim reviews in terms of implementation. And 12 countries, they have implemented it, but they have not really midterm review, so there is no really the opportunity to adjust it based on the shift in priorities and delays in implementation. And for one country, the strategic plan is outdated. There is no new strategic plan in place, and around 5 countries have not implemented the strategic plan at all. So this is a document, sitting, but they have not really, translated it into action. So this is not a good sign. And then we also looked into whether the strategic plan includes the Africa priority diseases. These are Africa priority diseases based on the emergency response point of view. It doesn't reflect the burden of diseases. So when we look into the diagnostic capability based on our assessment about these priority diseases, in the next slide, you see diagnostics are high for COVID, measles, Nigerian meningitis, polio, reflecting the previous investment. However, if you see, Zika, plague, dengue, Rift Valley fever, respiratory syncytial virus, and so on, there is no really, a strong diagnostic capability. This tells us that, investments in lab systems, if they are not done, considering the disease priorities, so that's where we usually find, the gaps during outbreak response. So this is from a real data. When the outbreak hits a certain country, for the first 6 to 8 weeks, the lab has a problem. Either you have not the equipment, or your equipment has not been calibrated, and then there are no people trained, you have no reagents. The blue line, which actually shows the trajectory of the estimated projected number of cases of a certain disease, and the lab capacity is not there. So at a critical time where you could have contained the outbreak from the source, So you don't have lab testing capacity. You have sent your specimen to the next country and you are waiting for the result to come. And your testing demand will match the projected number of cases at a later stage where you have introduced, point of care testing, you have maybe procured more equipment and so on. So the lab testing at a critical juncture where you need it, it's not there. This was the case with COVID, this was the case with Ebola, monkeypox, and it's the same for every outbreak. So the whole idea now is, can we make our labs ready from day zero so that they identify any potential pathogen and help in addressing the outbreak, the epidemic. So this was the case, for example, with COVID. When COVID was declared as public health emergency of international concern in January, there were no any African labs that have standardized COVID testing. You may say, that's fine because this was a new virus, but if you are really strong labs that has strong research and development capacity, you can create an in-house assay that you can apply it immediately until your commercial assays are available. But we were not in that position. For us, to scale up the testing, it took us until April, August, that's 3 to 4 months. By that time, the virus has circulated already across the continent, and testing at a later stage of the outbreak usually may not have a big meaning as compared to the initial testing. And then we wanted to see really, what are the challenges in terms of adopting new technologies. This is a slide that I adopted from a publication on TV product evaluation. Every diagnostic product has to pass through these 3 valleys of death. There are a number of challenges from development to commercialization because of resources, nature of your prototype test, because of a number of issues. And from commercialization to adoption, we have a problem, this regulatory approval, evaluation, and so on. And then from adoption to scale up, you have resource issue, feasibility introducing to a program, bureaucracy, administrative affairs, regulatory authorities, and so on, registration at country level. So the whole idea of the lab leadership now is, can we facilitate so that some of these valleys of days are smooth enough so that diagnostics move across this ecosystem. So this is really very, very critical. And every time we bring a new technology and then it starts somewhere. It enters one of the valleys and then it remains there. So the whole idea is, how can we really facilitate research and development in Africa so that we have some better diagnostic technologies to support our program. So integration is a big challenge. You have vertical disease program, but when an outbreak comes in, your strong programs can also be affected. This is a global fund assessment after doing the assessment of 502 health facilities in 32 countries in Asia and Africa. On the first 6 months of COVID-19, HIV testing was reduced by 41%. Because everybody was in panic mode. People don't go to the health facility. Healthcare workers have been repurposed to address the outbreak. And then TB referrals for confirmation of diagnosis reduced by 59%, malaria, and so you can see the impact. And then we also looked at the investment in the past on these disease programs and how they helped the progress during COVID-19 testing. This is the real data from our COVID testing program. This is the SARS-CoV testing per 1,000 population. It was easier to scale up testing in southern region on a green line, northern region on a blue, and the most challenging part was scale up of COVID-19 testing in Central and West Africa. That's a reflection of the lack of investment in the lab systems in the past. So it is important that, if you want to be prepared, you have to be prepared well for the known so that you will have a chance to stand the unknown. So this is a typical example of neglection of investment in your lab system, and this has been really a big issue during our COVID-19 response. So let me take you to entities. We know how important diagnostics are for neglected tropical diseases. These are around, as you know, 23 disease entities. We call them neglected tropical disease, but actually these are neglected communities. These are neglected people. So because of lack of diagnostics, our strategy for neglected tropical disease has been mass drug administration. This is expensive, you cannot do it properly, and it also is raising antimicrobial resistance. Azithromycin, which used to be the best drug, this was used left and right for trachoma control, and today you see significant resistance with azithromycin, as high as 60%. So if we had the ideal diagnostic technology, this could have shifted into a test and treat, where you individualize your treatment, and then you introduce this diagnostic technology at community level, and it simplifies your program. So we have rapid tests for HIV, for malaria, but we don't have that type of luxury in leishmania, trypanosomiasis, and so on. Emphasizing really the integration of diagnostic technologies. We looked at also the potential of multiplex testing. We did a survey, and around 35 countries, 35% of the countries assessed, they do some sort of multiplex testing, usually the respiratory panel. However, 65% they don't have any highlighting of multiplex testing. But the good thing is, they agree. They have shown really great interest to do multiplexing on respiratory and arbovirus panels and so on. This looks the future. It's very effective. It helps integrated surveillance. It will help also reduce some cost. Essential diagnostic list is hoped to increase access to diagnostics. And this is also the primary role of lab leaders. However, based on the study that was done by Winnie Coster et al., which was published on PLAS, Nigeria was the only country that has officially documented, established the essential diagnostic list, but we have a latest update that Kenya has done as well. Ethiopia is in the final stage. Some additional 2 countries are also finalizing the essential diagnostic list. And this paper also investigated what was the reason that we are not implementing essential diagnostic list. It's all related to governance. The lab directors don't have the authority, they have no funding. And it's also a concern for quality assurance in waste management, especially if you introduce testing to communities. And there's also limited strategic planning and policy issues on other disease programs except the vertical ones. So, the next 2 slides, I want to emphasize the importance of continental coordination. During COVID-19, we had the AFCO technical working group, which really helped us to navigate the lab support during emergency. They have been working on a number of issues, and some of you may be in this room, so I would like to take this opportunity to really thank all of you for your support to Africa CDC during that very difficult time. We worked together, both a number of diagnostics, trained people, and we had a series of scientific sessions, and in fact, we trained more than 28,000 people on rapid antigen testing, a massive scale, through the support of the Continental Technical Working Group. This working group today is working on capacity development, on testing of epidemic-prone diseases, on equipment maintenance, AMR, and also harmonization of regulation and manufacturing. These are important continental lab agenda items. Finally, I want to share with you the pattern genomics one, not to describe really what has been done, that was described on a number of times, I want to show this how this was a best example of continental coordination. What makes it special is this happened during emergency. There is no anything gratifying than seeing really, 400, 300 African scientists coming together and publishing on their work, on nature, on science. So we were really, on the spotlight. We were able to monitor, variants of concern, variants of interest. The African network was the one who identified Omicron first, and so on. This was the power of continental coordination. And this was really a network of national reference labs, research, academic institutions, supported by private sector, philanthropic organizations. A really, joint effort. This has continued today to expand really, to support other disease entities. Colleagues, I want to leave you with these important conclusions. Number one, let's really elevate the lab directorate. Let's give them the appropriate authority, whether you want to make them generals, marshals, whatever. Let's give them the authority. And then we can start complaining during that time. Now, we are not giving them the authority, and we continue speaking that, lab is weak. Second is, let's think about integration. I think we did, parallel disease programs for the last 20 years. We know, that's important. It has saved a lot of lives, but it didn't really, bring significant change in the system. So let's approach the lab system development as holistic approach, because we have seen the impact of emergencies on other regular services. And then finally, let's really, strengthen our continental coordinations, regional coordinations, because in this world, your neighbor's problem is your problem. You cannot be safe unless all of us are safe. So it's really important to think about that harmony, regional coordination and support. Thank you very much.
Thank you so much. I would now like to invite Dr. Susanna Kiowonka to the stage to discuss laboratory professionals for the 21st century building a force fit for purpose.
Good morning, ladies and gentlemen. My name is Susanna Kiowonka from the School of Public Health, Makerere University. It's a pleasure to stand before you and to hear the build-up or the excitement around laboratories. But I'm particularly excited about the health worker, the professional. So I'll be speaking to you from a researcher perspective on the health workforce, particularly the laboratory professionals. The title is Laboratory Professionals for the 21st Century. How do we build a force, a workforce fit for purpose? As we all know, and allow me to repeat this, laboratory professionals are the backbone of quality diagnosis. They are the unseen force behind the decisions made by the doctors to diagnose, to do surveillance, to monitor even treatment. But because they are not at the front face of the system, they are very neglected. And they provide services at individual level, but also at public health level. And they are a broad spectrum of expertise and cadres, cutting across the medical, the bacteriological, imaging, the x-rays, everything. So it's a broad spectrum of people. And unfortunately, they have historically been neglected across the system. Even when there was a wave of health system strengthening, the laboratory force did not feature much. They are under-researched. If you try to do systematic reviews, I have done a number of systematic reviews, you will barely find adequate literature beyond antimicrobial studies on TB and malaria. You don't find much literature on health systems with the perspective of the laboratory. So it's not just that the professionals are understudied, even the laboratory system itself, in terms of drug shortages, in terms of the procurement systems, in terms of equipment maintenance and the challenges therein. And for the professionals, they're characterized by the insufficient numbers, skewed distribution, low qualifications, limited career opportunities, constrained supply, low wages, high turnover. This is the same story for most of the workforce, but it gets worse when it comes to the laboratory workforce. Within the environments that they work, and it speaks to the history of the laboratory. Historically, the laboratory historically, Africa and other low-income countries had low diagnostic capacities. And most medical students were taught to do presumptive treatment. I remember when I was in medical school, you would be told that, okay, if the patient has ABCD, even before you send them out to do the diagnostics, you can start the treatment. And many old school medical students can tell you that. But it's because the laboratory budget is not a very specific budget. It's lumped with every other budget under the health system, and it gets the short end of the stick, meaning that the resources available for the laboratory have been historically low. And when they became available in the advent of global health initiatives, HIV, TB, malaria, they were focusing on particular diseases. And research I have done revealed that where there were adequate tests for HIV, TB, malaria within Uganda, you would find minimal tests for instance, chemistry, blood chemistry tests. Those were underserved within the same domain. So what has changed? What is changing? Right now, the laboratory environment is challenged by the changing disease profiles, increased life expectancy within Africa. So the disease profile has changed, but also we have the challenge of emerging, re-emerging disease threats, climate change, environmental threats, occupational health threats. There's so many, and it's a lump sum. And then right now, we are not looking at only clinical laboratories. We are looking at environmental, we are looking at occupational, geolabs, and how they actually impact on health. A recent study in Uganda actually revealed that when they analyzed the corn produced in Uganda, it has high levels of aflatoxin, and this has persisted. And as medical professionals, we all know the consequences of high level of aflatoxin. Everything ends up within the health system if it's not curtailed. Then there is a changing in service delivery models. Laboratory networks have been created, telemedicine, testing outside of the laboratories. Then the technology advances, genomics, automation. Some of these have not yet really hit Africa. For instance, automation in some laboratories that is being done, but not to the extent that it would be needed. And of course, like I said, the laboratory is a system within itself. It needs very advanced information systems in order to perform efficiently. So it needs a separate build within the system to make sure that the information system is working perfectly, the procurement, the human resource are in line. So a lot has changed within the lab, which requires us to do things differently. In Africa, we are a dancing continent. And when the beat changes, you can't remain dancing to an old tune. So we need to change the way we prepare the workforce for the new century. So how do we make this laboratory workforce fit for purpose? If we look at the intended purpose of the workforce in the 21st century, we need a workforce which is able to meet the challenges that we face before us, as well as the opportunities, the challenges of the infectious diseases, which are still persisting, besides the others which are re-emerging, the challenges of of surveillance, AMR, imaging, gene therapy, all those require a workforce which is trained to actually meet the challenge. We need a workforce which goes beyond the clinical laboratories. We need a workforce which is ready to handle the planetary health action which is needed to meet the sustainable development goals and beyond. Meaning that as we talk laboratories, we, the clinical laboratory people, should be talking with the food, with the climate, with the environmental health, with the vets, so that we are all building a force which is able to handle the 21st century challenges. And then we have technology innovations. Health is constantly moving and evolving and developing as we move to make services more efficient and more quality. So we have the point of care tests, the telemedicine, which has escalated after COVID. There are more instances of telemedicine right now. There is electronic information which needs to be carefully harnessed, automation. Drones are being used to transport some samples and even products. So there is a workforce which needs to be able to handle this. And Dr. Yenu talked about equipment maintenance. Research I have done revealed that almost all laboratories have equipment, but only about 50% of those equipment work. And this includes the big, costly equipment. They're not working for one reason or the other, but the arrangement to make them work requires importing sometimes technicians. And this is something you cannot ignore because it's such a huge capital investment within the laboratory. So we need engineers. We need to bring on board the engineers to work with the labs, to increase, to enable the commission, the maintenance, and the decommissioning of equipment. And of course, I've talked about the new service delivery models. We also need to talk about the market considerations, the need to have people, laboratory trained staff who can move across borders. In Uganda, during COVID, we had a huge border issue where we had, people wouldn't move from one border to the other because of delayed testing. So we need to have capacities built across borders. And then, of course, Yenu has talked about the leadership, the management, the governance, the need to build a force which is able to lead the new vision of Africa with regard to laboratories. So we need health workforce with appropriate skill sets, and they need to perform. We also need them to access quality training in adequate numbers, well distributed, but also retained. So when I think of the workforce as an academic, I think of the three pillars: planning the workforce. Who do we have? Where are they? What can they do? And can they meet the challenge? I think about development. For those who are in the workforce, what are their training needs? Does it fit the current agenda? How can these needs be supplied and by who? And then when it comes to management, how can we use the workforce efficiently? How can we retain them? How can they network and learn from each other? We have achieved a lot over the past decade. Right now, the gaze has turned towards the workforce and very pleasantly the laboratory workforce. So their policies, their strategies in line to actually draw emphasis, to put emphasis on the workforce. The WHO workforce strategy, we have the resolution on diagnostics, we have Africa CDC's pillar on strengthening public workforce, we have the One Health quadripartite, which is a collaborative framework across food, agriculture, across environment, across the WHO, across animal health, to coordinate the One Health approach. So we are doing well in terms of putting together policies that foster action around laboratories. Partnerships are critical. From all the literature we've reviewed, there is not a single success story without partnership. ASLM and its partners have worked concertedly to map out the workforce, but it's not enough. They've provided guidelines, they have trained hundreds of laboratory professionals across the continent and beyond. Africa CDC, AFNet have taught laboratory leadership and other workforce capacity building. We have the GLLP, which has taught leadership. We have opportunities for networking. The LabCorp, which has 22 countries hosted by ASLM, is a good place to start. Governance, it is important that bodies which are representing professional laboratories are actually given a voice, like Dr. Yen said. So far we have the Directors Forum in 42 countries, and so much can be done if these are empowered to actually advocate for the workforce and beyond. But there is still a lot to be done. In order to plan the workforce, we need to know what we have. Yesterday in a session, we discussed the challenges in actually estimating the need within the lab, because the laboratories are so dynamic. Some of them are referrals, some of them are automated, so the workflow differs from lab to lab. But there is still need to map very carefully the laboratory workforce in terms of numbers, skill mix, distribution, movement. But most countries actually have less than 1.5, 1.3, and this workforce is mostly urban. We need to map the competence needs. In terms of the competencies needed for the 21st century, what do we have? What is lacking? What can be built? I mentioned the laboratory, the engineers. Then we have the community laboratory workforce. We are getting point-of-care tests, self-diagnostics. How can these be harnessed, and who would supervise this? Then we have the challenge of the capacities of training institutions. We have outdated curricula. The curricula we have in many of the schools don't fit the current demands for the workforce, and they need to be updated. How much are they putting out? We have strategic plans, but Dr. Yenu has already talked about those. A few countries have them. Many countries have not even implemented them. When it comes to pre-service training, African countries have increased their capacity to train, but there are challenges. The cost of the training, the facilities, the curricula, everything still remains in limbo. There is need to upgrade that. The shortage of qualified lecturers in both public and private, and then the fact that most training facilities actually offer certificate and diploma. In Kenya, which is performing a lot better than most of the African countries, and South Africa, I think, 1 out of 3 registered training institutions are from the private sector. There is opportunity here to leverage superior infrastructure through public-private partnerships, where students can be attached to the superior laboratory infrastructure in the private sector to get that kind of exposure. And of course, the need to refine or to update curricula to fit our current and projected skill sets. We need to develop the workforce and move from a reactive to a proactive to a transformative approach. Historically, most capacity building efforts on the workforce have been reactive. When there is a challenge, we will always get training needs met for HIV, TB, malaria, even for COVID. A lot of training was done for COVID, but this does not address the underlying problem. So it needs to be more proactive. We need to know the post-service training needs in terms of technical needs, but also technology. Right now, the workforce needs to be very tech-savvy. We need a workforce which is able to handle technology. We need the quality assurance, standardizing the training across board. God forbid you find yourself in another country and you have to run tests, but you're not really confident that they're able to do that. So access to continuous professional development is critical, and as much as possible, if it can be virtual and self-driven, with some opportunities for hands-on. I cannot overemphasize the importance of networking, core learning, benchmarking. I think ASLM's COP has shared some of those good practices, leadership and governance, but also the need for multidisciplinary collaborations and partnerships. There is also need to deliver highly specialized laboratory services. With regard to managing the workforce, we need managers who are able to handle the new alternative models of service delivery to make them more efficient in the hubs or the reference labs. Managers who are able to handle the telemedicine issues, the mobile laboratories, handling the point of care tests, especially when they are in the community, the task shifting to the community. These need to be very well supervised. And then we need the performance management. With regard to the new laboratory workforce, we will need to revise curricula, especially because the cadre we now require differs from the cadre we had 10 years ago. So we need to revise the curricula, revise the staffing norms, and even the job descriptions for the lab personnel. Incentives. I said yesterday in a session that laboratory workers work in a very stressful environment, focused on very clearly cut out work to do, and it can be very stressful. So there is need to give incentives. They have historically had poor culture, poor career structure, and poor work environment, which needs to be addressed. I won't go into gender and the mental health. It's another issue that needs to be addressed in managing the workforce. So how does the manager, the 21st century manager for the workforce in the laboratory look? According to research, most countries have a workforce which is below 40 years, meaning that you have a younger population, a younger age group. These are the millennials, these are the people you're going to be working with, and the manager needs to be collaborative. Millennials require more communication. You need to be a very good communicator. You need to be connected. The millennials require flexibility, creativity. So it's a new type of manager that is needed to handle the stresses of the 21st century in the lab. Finally, I want to emphasize that whatever changes are made, we cannot get away with ad hoc, piecemeal, short-term investments. They have not, and they will not fundamentally solve workforce shortages and challenges. For the workforce, we need to do better. And right now, the spotlight is on the workforce. I implore that we all do better. Quickly rounding up, we need to map the workforce. We need to map existing capacity building efforts and how they can be harnessed. We need to ensure that as we build the hard skills, we are also building the soft skills so that they can lead, they have agency and networking. We have to have managers who are trained to harness new service delivery models. And we need to incorporate performance management within the package. We need to make sure that their employment environment, their employment and their workplace is supportive. Partnerships cannot be underrated. And finally, research on the laboratories, systems as a whole, and workforce specifically is critical. Thank you very much.
Our theme for today has been challenges and opportunities, the good, the bad, and the unexpected. And we have had three distinguished speakers give amazing presentations on these varied topics that they've just shared. Please join me in thanking all three of them, Dr. Keke, Dr. Sarah, and Dr. I invite you to walk up to a microphone so that they can take your questions. And if there's one thing we have seen this week is a rich engagement and dialogue, so please do not hesitate. We look forward to answering your questions. I think we have one on this side of the room. Please go ahead. Please also introduce yourself and share who your question is for.
Good morning, and thank you so much to the speakers for wonderful presentations this morning. My name is Dr. Christina Mwangi. I work with CDC Uganda. I think mine might be comments, but maybe I'm also be asking for your perception at how we can move forward. And I think my comments, questions are really addressed to Africa CDC. So I'm looking to Africa CDC to help at continental level to address the laboratory profile. What can we do? What can we do with heads of states? What can we do with ministers? I'm not talking about ministers of health, but ministers who are responsible for the purse, for the fiscal facilitation of laboratory networks in our various countries. Our biggest bottlenecks have been around the levels at which the laboratory medicine approaches the decision-making platforms. 2, the levels at which the laboratory medicine is placed in the financial food chain. Have we articulated the cost of not having reliable diagnostic systems to the policymakers in a language that they understand? I applaud my sister from Makerere University who have actually outlined a lot of the issues that affect laboratory medicine. However, I applaud ASLM for making sure that we have this forum, excellent forum. We are speaking to ourselves. At what levels are we going to speak to the people who actually make a difference in terms of making sure that the laboratory networks are adequately financed to address the issues that you have brought up? How can we talk about the implications for medical financing when we are not talking not only at reference laboratory levels? Because if we talk at reference laboratory levels, a lot of them have been catered for and can actually do exactly what you're talking about, genomic sequencing. But I'm looking at how can we stem the flow as low as possible in the healthcare system? And how can we translate this into policymaker language where they understand that the cost of not having a reliable and accurate laboratory network at primary healthcare level actually costs them a lot more at the policy, at the tertiary level, so that that language is translated into policymaker language where they understand that as the Minister of Finance or whoever is responsible is making their financial budgets, that budget for health is actually affected by not having a strong laboratory network at grassroots level. Thank you.
Thank you, Dr. Mwangi. We'll take a few questions and then the panel can respond. I see one on the side of the room. Please do approach
Yes.
the microphones with questions.
Okay, I have a question. Good morning. I'm Alessandro Marcello from the International Center for Genetic Engineering and Biotechnology. And thank you for the presentation of today. Excellent presentations. My question is for Dr. Feke and concerns the introduction of new assays. You have explained very well that the plans of Africa for covering this Death Valley for the acquisition of new assays for essential diagnostics. My question is, how are you planning to do it across a really fragmented regulatory framework across different countries in Africa? Thank you very much.
Thank you. We'll take one more on this side of the room and we'll let the panel respond.
Good morning. I'm Sila Vanessa Masego, NICT South Africa. Thank you for the presentations. I think my question is basically about how we prepare the industry. So these are the organizations, or if we may put it, public sector that employs laboratorians. I'll make an example. In South Africa, we've reviewed the curriculum. We're now producing medical laboratory scientists. these are laboratorians that are ready to enhance the new 21st century laboratory. But the laboratories are not ready for that. So how do we prepare the employer for the new career? Because we're ready to utilize the new skills. Our minds are set up to do molecular assays, and we want to also be to get the salary that speaks to the qualifications that we have. So how do we engage with that? My second question is also regarding other prospects of training. As the field epidemiology program. In South Africa, the laboratory part has been taken away, and now we just have the ASLM. It doesn't include the laboratory. So such changes, what impact do they have on the laboratory workforce? Because we want to see the laboratory workforce being prepared for the new century and being prepared to address all the new public health problems. Thank you.
Yeah, thank you very much. Christina, I have no really short answer for you. How to elaborate, the lab systems and to talk generally at the highest level. But it will be a process. Number one, it should start from us. As a laboratory community, I think we have been talking to ourselves. We need to go beyond and engage other sectors. For example, there is some good movement in addressing biosafety and biosecurity where we are trying to engage parliamentarians. That's a good example. So we need to talk to the appropriate people. We need to advocate. And we need to use also all available political avenues from our side. We have made lab diagnostics, especially in preparation for pandemic preparedness and response, as the flagship program for our Director General. Wherever he goes, we ask him to speak about the lab, how important it is. But we have the opportunity. I think COVID, put the lab system on the spotlight, and I think it's I hope it's near to the people's memory. So I think we need to use this opportunity and advocate, for resource allocation for laboratories. And as you mentioned, the creation of Lab Directors Forum. That's a good start, so that we organize ourselves. And then it's also the choice of our language when we speak. So we go and talk in details about sequencing and so on. That way, the ministers and finance ministers, they don't understand. So I think we need to communicate in a very impactful way. For example, if you want to tell about antimicrobial resistance, then instead of percentage and so on, we need to convert that one into economy. What we are losing as a GDP in the African continent in that particular country. So it is a way of messaging. I think we have come a long way, but we need to continue really more advocating and engaging relevant people. On the fragmentation of regulatory, that's a challenge that stands today. What we are working is to put in a coordinated mechanism for registration of diagnostics. We recently have started working with the AUDA-NEPA, the Africa Union Development Agency, and we have established our diagnostic advisory committee. And the whole idea is for manufacturers to approach us to coordinate evaluation. And then once evaluation is done, we communicate the regulatory authorities. Using that evaluation data, they should be able to register diagnostics instead of asking the companies to evaluate diagnostics in every country. It's really time consuming. It's also resource intensive. And we have also the African Medicines Agency setting up itself in Rwanda. And the whole idea of their focus initially maybe on pharmaceuticals, but I've also included diagnostics in their portfolio, and hopefully we will have a unified regulatory approach for evaluation of diagnostics. Today we understand the challenge. There are also some movements at regional level where countries have started regulatory convergence once it's registered in South Africa, so you don't need to really ask evaluation in Zambia and so on. So I think those things are happening. It's a good sign, but we have really our plan and our objective to really to get that convergence of diagnosis registration. And then I will leave the rest for my colleagues.
I'll try to address the question on how do we prepare the industry, and maybe what I can say is that most labs are actually gathered around some associations because they need to be accredited, and part of that can be used to create the awareness and the mindset change with regard to the new cadre of professions who are likely to come out. Of course, not every lab is going to be able to do high-level diagnosis, but I think as part of the association, as part of a continuous professional development, the lab owners get on board with regard to the new cadre. Regarding the question you asked about the FETP, the field epidemiology, that the leadership part has been taken away. It's unfortunate, of course, but I would also like to say that the GLLP is still offering a laboratory leadership program, which laboratory leaders can take, can benefit from. Over.
We have 5 more minutes, just seeing if there are any other questions. I think I had seen, please go ahead.
Thank you. My name is Donato Fonbeta from Ministry of Health, Tanzania. So my question somehow request and comment on the issue of workforce development. So from my experience, not generally Tanzania data, I graduated with about 85 of us, and less than 35% is employed by the government, and very few of them are employed by, let's say, CDC and other organizations. So we have a big population of laboratory scientists that are unemployed. I was just trying to understand on building the workforce for the 21st century. And we know that also laboratory is actually a good business. So how do we support this large population of scientists that are currently not employed anywhere, but they have professionals that can actually support them? And I'm not very sure about this, but I even had some of these famous laboratories like Lancet Lab. They're not exactly founded by people of laboratory professionals. So how do we support these people to actually understand the business and link with those maybe manufacturers to support them to have the necessary knowledge and skill? Because even private health facility, they support increasing access of these services in the community. Thank you.
Thank you. In the interest of time, we'll make these questions very short. That side of the room, and then we'll come back for the last couple.
Thank you for the presentations. My name is Tumega. I'm from South Africa, from the public health lab system. So my question is also to Dr. Kiwanuka. In terms of the technical and technological skills, have you found any sort of examples of success stories in terms of implementation of new technologies, allowing staff to use things like artificial intelligence, big data to impact patient care? Because in resource limited settings, we struggle even to get a stable connection to your work computer. So when it comes to like very advanced technologies, it doesn't make a difference to train someone in AI, in coding, but then they can't use those skills in the lab. Thank you.
Thank you. Please go ahead. This side of the room.
Thank you very much. My name is Ben. I'm from Kenya. And my question goes to Dr. Suzanne. In your own assessment, when you're doing a systematic reviews, do you think some of the bodies that are formed to regulate laboratory staff also act in a way to demotivate them? Because I know in the case for Kenya, you find people who went through the Kenya Medical Training Colleges, they have a license, and then you have a different set of staff who went through the universities and trained in the same laboratory courses, but you find the ones who went through the medical colleges and are having diplomas earning more than their colleagues who went to the universities. And that, I think, goes up to speak a lot about the demotivating factor in terms of remuneration of the laboratory staff. So what is going to change that? Thank you.
Thank you. We'll do the last three questions really quickly.
Thank you very much. I'm Ignatius from Ghana, Ministry of Health. I have deep interest in the concept of community laboratory health workforce. In your reviews, have you come across where this concept has been implemented? Just shed a little light on that. Thank you very much.
Thank you, Professor Marufi, and then our final.
Thank you very much, Lucy. I'd like first of all to thank a lot our friends for their very good presentation and good also ideas and thoughts that you shared with us regarding the future of laboratories practice in the 21st century. I think we are talking about the future. One function and role of laboratory in the future that seems for me under discussion and debated in our area is the role of laboratory and public health laboratory in supporting the activities and function of local manufacturing of vaccines and health products. I think this function is one now big function of preparedness for pandemic and epidemic preparedness. It is included in the strategy of IU, of Africa CDC, and in a lot of also frameworks. But the role of the laboratory in surveillance of quality and efficacy of vaccines and health products, it is one function that is very important, I think, to discuss, to debate for the future. In the same importance, like for example, we survey or we monitor the efficacy of antibiotics, of antimicrobial resistance, but also vaccines and health products should be evaluated and assessed in terms of quality before to release them and after using them in the market. So this function, I think, for me, is under evaluated and under studies. That's why my question is, I have one question and recommendation for my colleagues and friend, Dr. Liu. The question is how we can integrate this practice and function into classical function of public health laboratories as diagnosis and surveillance. The second question, recommendation for the question, I think we need, my friend, in Africa to have some guidelines and framework that guide us in our institutes to develop this function of controlling, evaluating, and monitoring the quality of vaccines and health products that will be locally manufactured in our countries in Africa. Thank you very much.
Thank you, Professor. Our final question from up top, and then we have to go to the panel to close us out. We are at time. Please go ahead.
My name is Professor Nabila from the University Water Project. So my first one is, we have talked a lot about building capacities, but one limitation I have seen through the conferences is very little about the basic sciences, and yet from COVID-19, the immunology you could see coming out of the reports that were coming out of China suggested that the immunology was a big deal for patient care, but we have very little of that represented in the public health system. So how do we address that? The second one is in clinical rounds and so on, rarely the laboratory staff represented, and yet with the newer technologies and so on, we actually can contribute to diagnosis really just by suggesting other pathogens that could be causative for what is being seen. How do we address that? And then the final one is a lot of our funding is donor donor driven. How do we get these discussions? How do we get the donors who sometimes can contribute to change locally to drive some of the change that we want to see?
Thank you. So very fast round robin from the panelists before we close.
Yeah, very quickly, the first question was on the surplus health workforce, but very few of the workforce are actually recruited. This has to do with the budgets, the fiscal budgets for workforce, the budget ceiling, and the fact that the laboratory has not been given that prominence. So the first thing that needs to be done is to estimate what is really needed, and then we can lobby governments to actually increase the recruitment. But beyond that, I mentioned in my presentation the need to develop a mindset of entrepreneurship where these lab people can actually provide services privately. With regards to the question from South Africa on the technical and technology and the skill and the inability to actually exercise their skills because of the lack of stable connection, I am thinking here that not every lab might require the very high level of training, not every lab personnel. So competencies are needed on the basis of what the lab is doing, and that requires very clear calibration of what competencies are needed for different cadres. With regard to the question on professional bodies at war, this is not new. We have professional bodies at war in Uganda, and a tug of war between who regulates and who doesn't and who gets which benefits. I think this is a professional body issue, a governance issue, the need to actually have mediators who can clean up our self-created mess, so to speak, and to make sure that professionals feel valued. There was a mention of which community health workforce has been used to do diagnostics. Actually, this is quite common because of the fact that in Uganda, actually, we have rapid diagnostic tests being done in some of the settings. We have HIV self-testing. We also have some sample collection at community level. So it has worked in some areas, but the referral is also needed and the supervision of this workforce. Finally, you mentioned the basic sciences and the fact that the lab people are not allowed in the award round. This speaks to the fact that our curricula have not been up to speed to meet the current demands, but also the traditional constitution of the medical training. The ward round is usually the medical doctors, even struggling to get nurses onto the medical, the ward round has been a challenge. So there is definitely a need for a mindset change because health workers work as a team rather than as individuals, and training them in their silos has been a problem historically. Over.
Yeah, quickly, Professor Marufi, I think those are important recommendations. The lab capacity that we are building today, especially the genomic sequencing, we are applying it to surveillance to improve surveillance for public decision making. But we need to go beyond that, and we need to use that technology to identify targets for vaccination and vaccine preparation. And if you see all of the discussion today on vaccine manufacturing, the challenge is we don't get raw materials in Africa, so you have to bring from somewhere else and start assembling but we need to have our own research and development capacity. We need to invest on that and get raw materials and do a lot of pattern discovery work and so on, and identify your vaccine targets. And at the same time, you need to use a lab also to monitor the efficacy of vaccine. During COVID-19, South Africa did a very good job in evaluating the effectiveness of vaccine, and they had even made a decision to not to introduce a procured vaccine because they identified that it was not really the right one in terms of its efficacy. And we need to use also the lab capacity to monitor the efficacy of vaccine after we deployed it in the field. So I think this is a very important function of the lab. We speak on regular basis, so I'll be happy to take this to further conversation. Thank you.
Thank you, Dr. Dr. Any final remarks from John?
Just a couple. First of all, an extension to Yene's response to Professor Marufi. So the examples I gave in my talk were examples of how, even though we've just started, the genomic information we're generating is at no cost, now generating information that is informing vaccine development. And so this is actually one of the powers of genomics, that even in the future, if there are future vaccines that we can think of that we have not thought of now, we can retrospectively mine those genomes and get that information. And this is one reason why genomic science in particular is very cost effective, because there are outcomes now that we cannot potentially imagine. Now, the second question that I just wanted to offer a brief response to was the importance of basic science. And, having set up very recently a genomics program with a lot of bioinformatics, a lot of precision molecular biology, one of the challenges I've had is bringing in people who have a foundation in medical lab science. And this is actually, these are people who out-competed those who went into basic science degrees. But unfortunately, their programs did not have enough of a foundation in molecular science. And so I'd like to encourage those of us who are writing curricula that it's true, there are all these applied things that medical lab scientists have to learn, but that foundation is important for when a field makes a shift. Because when a field makes a shift, it is the understanding of the basic science that allows you to quickly jump on bandwagons. This is why physicists, for example, were able to become molecular biologists when the molecular biology revolution started. Thank you.
Thank you so much. Please join my co-chair Amanda and I in thanking our panelists for the wonderful presentations and answering the questions this morning. With that, this session concludes. Thank you everyone for joining us this morning.